Hi everybody, this is Professor McLaughlin and I'm going to be doing your lecture on a video for the very first time, so bear with me as we go through this. And if you have any questions at the very end and you're not able to figure it out from your reading and from each other, feel free to send me email or save your question for the following week when we meet together. So to start, I would like you to think back to the last time that you had a massage and how it felt when you got up from that massage table. Maybe the last time somebody rubbed your feet or your shoulders, or maybe if you gave someone else a massage. So that feeling that you can imagine, just hold on to that feeling. And remember, if you had very much pain when you came out of that massage. Most likely not. And if you want to test this theory, you can ask somebody around you to massage your back. But we're going to go into more detail as to why that occurs, but there are many different things that we'll talk about today where all of this will start to make more sense. Also, I'd like you to prepare either a pen or a paper clip to keep with you for during this lecture. And then also, if you have some chocolate or something spicy that you can eat at some point, or it could be spicy chocolate, put that to the side. And we'll talk about that a little later when we talk about endorphins. But most of the time, when you have a massage, you get these feelings released, okay? You have these natural endorphins. And it happens when you're smiling and laughing as well. And the pain just melts away. Natural endorphins work exactly the same way that opioids work, okay? So that we have these opioid receptors in our bodies. And they're kind of around. And the only thing that fits in them are opioids, such as certain narcotics that we give, pain medications. But our natural endorphins also take that exact same effect and block out pain. Okay? Other things that can cause these natural endorphins we'll talk about in a little bit. So we're going to be covering mostly pain. Your chapter covers temperature, sleep, and sensory function. So I do want you to review those, but for your exam purposes and for the purpose of the hospital, we're going to focus mostly on pain. When was the last time that you saw someone in pain? Like really saw someone suffering? Was it someone in your family? Was it yourself? Was it a friend? Was it a stranger? And how do you respond when you see someone in pain? There's no easy answer to that, but it's something that we have to think about as we prepare in nursing school, because we will be faced with pain quite often. That's part of why we're here. And just giving someone a pill is not going to be enough a lot of times. It takes a lot more than that. And as you guys know from experience throughout your lives, there's spiritual considerations and emotional considerations. So when you walk into the room on Saturday and you have a patient crying because they're in so much pain, what are you going to say to them? Or what are you going to do? One thing that you'll find is that you'll start to build what's called a spiritual toolkit, so that when you're in moments where people are spiritually suffering or even just physically suffering, you have some tools that you can use if they're appropriate. There's a verse that was once read to me it's in 2 Corinthians 1, 3 through 6. And I'm going to read it to you. just as another option. Praise to the God of all comfort. Praise be to the God and Father of our Lord Jesus Christ, the Father of compassion and the God of all comfort, who comforts us in all our troubles, so that we can comfort those in any trouble with the comfort we ourselves receive from God. For just as we share abundantly in the sufferings of Christ, so also our comfort abounds through Christ. If we are distressed, it is for your comfort and salvation. If we are comforted, it is for your comfort, which produces in you patient endurance of the same sufferings we suffer. So, depending on your spiritual background, that can mean different things to you. But what it comes down to is letting your patient know that they're not alone. Even if that means just squatting down, getting in front of them so they can see you eye to eye and telling them, you're not alone, I'm here for you, we're going to figure out what we're going to do, we're going to work together, and we're going to get through this. That open communication and allowing your patient for a split second to see that they're with another human being who cares deeply about them can totally change the face of that pain. So what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So this was, this was a definition that you would be more likely to see by the International Association for the Study of Pain. Now, what does that mean exactly? So I want you to take your pen or the end of your paper clip, and I want you to push it into one of your fingertips, okay? And I want you to push it until it hurts and then remove it, okay? Now you felt pain, okay? You felt some sort of pain, but do you have permanent damage in your fingertip right now? No. It was potential tissue damage. And I think it's important when we think about pain to realize that it's not necessarily permanent damage or any damage at all. Now let me give you another definition to think about. Pain is whatever the experiencing person says it is, existing whenever he says it does. So as we talked about in class, pain is very subjective. If that's the one thing you bring away and you remember when you're on the floor, it's to trust your patient. And to go with whatever pain level they give you. Now, how do we determine pain in the hospital? So think back, if you have a patient on Saturday, how would you determine how much pain they're in? What would you say to them? Some of you may be saying, I'll ask them what their pain is like. And that's great. But we always use a numeric scale whenever possible. So I would say, on a scale of 0 to 10, can you tell me where your pain is? 0 being no pain at all, and 10 being the worst pain you could ever imagine. Now, if you don't give them a reference on what 0 is and 10 is, you may not get an accurate measurement, okay? So make sure that you remember to do that because not everyone has heard of a pain scale. But numeric 0 to 10 is generally what we use. Quickly, I'm going to go through a couple pain theories so that you know what the pattern is over time with pain, what we've thought about pain. The specificity theory looks directly at the amount of pain related directly to the amount of tissue injury. So if one patient tells me their stomach hurts 10 out of 10 pain, and another patient says 5 out of 10, that would mean the patient who said 10 out of 10 would have the most damage, okay? Which we all know is not necessarily the case at all. Why isn't that the case? And the reason is there's a lot of other things that come into effect and change our pain. And that could be emotional stress, a recent breakup perhaps, maybe someone, your spouse of 50 years just passed away at a different hospital. So now your pain went from a 5 to a 10 because your heart is breaking. So there are many other reasons that your pain can be exacerbated. So this theory doesn't cover it all. Next, we look at the gate control theory. The gate control theory basically talks about the fact that we have large nerve fibers and small nerve fibers. And sometimes when the large nerve fibers are stimulated, they can actually inhibit pain from passing through to the brain. So pain, and we'll talk about this in detail later, and it'll make more sense. But for now, just consider the fact that if you have small nerve fibers carrying pain and large nerve fibers carrying other things, other sensory messages, the large nerve fibers actually can inhibit the process of pain going through and the brain interpreting pain. Okay, so sometimes the gate is open and sometimes the gate is closed. Okay, if the gate is open, the pain is able to get through and we're able to actually feel pain. All right, and we'll come back to this a little bit more. Now there's the pattern theory. Now the pattern theory basically talks about the ability of our central nervous system to repattern itself. So first, I would need to ask you if you know what the central nervous system entails. So think to yourself, what is a part of our central nervous system? Okay, the center part. So if you can remember looking at the center of your body, that's how you can remember the central nervous system. The brain, okay, if you take a straight line down your body, the brain, and then the spinal cord, okay? Those are the main components of the central nervous system. So if you stimulate the central nervous system in different ways, okay, you can actually repattern the central nervous system. It can work differently over time, depending on what disease is constantly affecting it. Okay, one really good example is neuropathic pain. And we'll talk about neuropathy. But neuropathic pain, okay, neuropathy is a disease of the nervous system. So neuro being the nervous system, pathy being disease. Okay, so some disease of the nervous system causes pain. So the classic example of neuropathic pain is going to be in your diabetic patient with peripheral neuropathy. And I'm sure a lot of you have heard of that, seen it, or experienced it, possibly. But that pain tends to be a burning, shooting, sometimes tingling, almost like your foot is falling asleep and it's coming back to life, that feeling that none of us enjoy. That can be a more constant, permanent pain. In patients with uncontrolled diabetes, because diabetes actually can damage the nervous system. So we'll talk more about that later as well. Okay. Then there's a neuromatrix theory. And this kind of encompasses pretty much everything. And this is a pretty good theory because it looks at a holistic, dynamic view of pain and basically talks about the plasticity of the brain. So the brain being flexible, okay, and being able to change. And the reason this is a good theory is because it takes into account the possibility that can we have pain without an external stimuli? So I'll ask you again, can we have pain without an external stimuli? Sometimes we do see this. Can you think of a classic example? Phantom limb pain. So my father-in-law sawed his finger off many years ago So his finger is non-existent, but he still gets pain and even itching sometimes at the tip of that finger. Okay, so that pain is not from an external stimuli sending a nerve message up to the brain to, and then back down again. That's not happening because there's actually no peripheral nerve there. So that's why the neuromatrix theory is kind of nice, because it takes that into account. Okay, you should be able to identify these components and tell me what this is a picture of. If not, please go back and review. This is classic anatomy for understanding pain and the nervous system. Review myelin, okay, the purpose of myelin and the purpose of neurons. Nociception. Nociception is a term you have to know. It's our perception of pain. Now notice I said pain and not massage, not tickling, okay, but pain. So in order to feel pain, you have to have nociceptors, which are free nerve endings, and they're everywhere. They're not just in the skin or just in the arteries. They're in the organs, okay? They're in all your muscles. I mean, we all know that. We felt that. They're in your joints. And there can be all kinds of different stimuli, okay, that can stimulate these nociceptors so that you actually perceive pain. So what are some examples of mechanical stimuli for pain? What pops up in your mind? So this is kind of the more straightforward one. You guys probably thought of car accidents, falling off your bike and, breaking your bones, being punched, in the face by an external force or something. Okay, that's more straightforward. What about thermal stimuli? What comes to mind? And understand that thermal could be hot or cold. So many of you probably said burns for hot. Okay, that could be a painful stimuli. It would be from burns. And frostbite would be an example of what could cause, or what would be the end result of a cold stimuli. And what about chemical? So chemical can be caused by acid, acid exposure, or even like really hot chili peppers is another example. Can cause a burn in the end, a broken skin. And visceral, if you don't know what viscera are, okay, that's referring to organs, and that's a term you will learn over time, viscera. Go ahead and log it away for now. So what would be an example of an organ that would cause you pain? It could be a lot of them, but certainly your heart, right? When we have, when a part of our heart is dying or the cells are being deprived of oxygen, that causes pain that's specific to the heart. An appendix that's inflamed will also hurt a lot. Some of you may have had your appendix taken out. So those are organs that are actually causing pain. This is a fun little animation for your viewing pleasure. And if you don't know by now what this is, you have to go back and review again. All right, this is where everything gets pretty fun and really exciting. So you see all these different nerve fibers, and notice they're all these different sizes, okay? So when we're talking about which nerve fibers transmit to the brain the fastest, okay, with messages, the larger the diameter, the faster it will be. So looking at this, which one is going to be the fastest? You're looking at the alpha, right? Notice the speed listed at the bottom and how it correlates with the diameter. Now, do you remember back on that slide when we talked about the gate control theory? We talked about large fibers and small fibers. And I talked about how the smaller fibers carry pain. We're going to go into more detail on what all the different sizes carry, and you'll understand why some messages get through and others do not. So alpha, okay? These are, if you remember, the largest, okay? All the way on the left, those large diameter nerve fibers. So for your excitement, I have chosen celebrities to represent each fiber. I chose Robin Williams because he speaks really fast and he tends to move pretty quickly. He's the fastest fiber. And this particular fiber carries information, messages about proprioception. What is proprioception? This is a word you'll start to practice with in health assessment, but for those who guessed, and for those who didn't, proprioception has to do with your understanding of where your body is in relationship to the world around you and the rest of your body without actually seeing it. So if you close your eyes right now, just go ahead and do that. And I tell you, keep your eyes closed and wave your hands about 1 foot in front of you, right in front of where your eyes would be, okay? You can't see your hand, but you know that that's where your hand is. You can do it right now. I'm doing it as we speak. Okay, that's proprioception. It's your understanding of the relative position of different parts of the body. So Robin Williams does this fantastically. Notice I didn't say anything about pain with these alpha nerve fibers, okay? Alpha beta. So these are the second fastest, okay? And I chose Oprah because these nerve fibers carry the sense of touch. They also carry the sense of vibration, okay? So when you're thinking about a massage or somebody vibrating, those little foot vibrators, that is what we're talking about, okay? The alpha beta nerve fibers. And Oprah does a lot of hugging and stuff. Notice again, I didn't say anything about pain because these just carry the signals of touch and vibration. Alpha delta nerve fibers. So now we're down to the third, okay? So it's the third fastest or second slowest, however you want to think about it. Okay, and this carries acute localized pain and temperature. Okay, so now we're into pain. So this one responds to mechanical stimuli, okay, when you push that pen on your finger, temperature stimuli as well. You touched a hot pot on the stove and you jump back, okay, so that's your alpha delta. It's myelinated, remember that. Remember it had that extra layer around it that the C fibers did not. Okay, so it goes a little faster. And then finally, we're at our smallest diameter nerve fiber, which actually travels the slowest. Okay, so these are the C nerve fibers. They're related to pain, temperature, and itch. I don't know why I chose Clint Eastwood as somebody who's painful and itch and slow, and this type of fiber produces a slow burning, long-lasting pain, and for some reason Clint Eastwood came to mind. So anyway, a great example to relate delta and the C nerve fibers, okay, is you sprain your ankle. I have unfortunately sprained my ankle too many times in soccer. Right when it happens, you have this acute pain. Sometimes you feel a snap. You fall to the ground. Tears well up in your eyes. And all you can feel is that pain. Then you kind of get a hold of yourself and you limp off the field, or you limp away, or you get someone to help you get into a car. And what happens to that acute pain? It starts to kind of recede, but then by that night, let's say you've iced it and you have it up and everything, what do you have? You have that kind of dull, long-lasting, throbbing pain. Okay, so that comes last. Your delta fibers are going to save you from the immediate emergency. Okay, whatever's threatening you, they're going to get you away. But then you're going to have the slow, dull pain lasting later. Before I move on, I'd like to mention one more thing. Have you ever gone and gotten a flu shot and the nurse actually rubbed your arm right after she gave you that flu shot? She just rubbed your arm, and then you're like, oh, I didn't even feel that. Didn't really feel any pain. Or that worked great. Or maybe you're a parent or a big sister, big brother, and a kid, a little one bumps their head and you rub their head. And then they're like, oh, I'm fine. They didn't even really notice. So what's happening there? You're actually stimulating by rubbing, you're massaging, that touch. You're stimulating those nerve fibers that are larger and faster, and they inhibit your pain response. So the smaller fibers, the delta usually, are inhibited by that gate control theory. So that's why it works. A lot of nurses who give vaccinations don't understand the connection between why they rub the arm afterwards, but they know that it works. And so now you guys actually understand, and that's a wonderful thing. Transduction, transmission, perception, modulation. So these are pretty straightforward, and you can always go back and review these. This is just how pain, where is it going? Okay, we talked about the nociceptors and where are they at? So look at your finger. You have nociceptors in your fingertips. Okay, that's why when you stabbed it with a pen, it hurt. Okay, so once that happens, that signal goes straight to your spinal cord. So there's a dorsal horn. It's called a dorsal horn, but if you took a cross section of your spinal cord, you would see something that looks like a horn. Okay, that's actually where the signal gets transmitted to. Okay, so you have those nerve endings, right? Those nociceptors. The stimuli shoots up to the dorsal horn, okay, into the spinal cord. We have different systems that perceive possible pain. And there's also something called modulation. This is important. So there are different things that can either facilitate the transmission of pain or inhibit the transmission of pain. Okay, and that can happen before, during, or after perception. So modulation can be moved around here on this slide. It's not necessarily last. There is the dorsal horn that you can see. Okay, so here is the dorsal horn, and that's important for you to note. So that when you hear that word, you understand you're looking at a cross section of the spinal cord. Notice here, C fibers, slow. Remember, that's Clint Eastwood. Okay, and then you've got that delta, right? So it's going to be fast, localized, acute pain, right? So everything kind of hangs out, ends up connecting in here. Now, where does it go from this dorsal horn? And here's another. It goes to the brain. Okay, so most of you probably realize that. Okay. Now we have neuromodulation of pain. So again, modulation is either, increasing the pain that it's transmission or decreasing it, inhibiting it. We're going to talk a little bit more later about this when we talk about inflammation. But just know that your neuromodulators can be triggered by inflammation, injury of the tissue. And then you have certain inhibitory neuromodulations. Look at those at the bottom. These are the interesting ones, okay? Because we want to know, how can we decrease pain, not only for our patients, but for ourselves, for our family members, okay? And notice there's certain things listed here, such as serotonin, norepinephrine, endorphins. So remember those endorphins that you get from chocolate, from exercise, okay, from sexual activity, from massage. These are things that can trigger endorphins, make you feel really great, and actually inhibit the pain that's coming through from some other part of the body, perhaps. GABA, you may recognize. Gabapentin is a particular drug that works on neuropathic pain. Not something you have to log away right now, but just something you may recognize. Does the brain actually hurt itself, the brain tissue? No, actually, there are no pain receptors in the brain itself. So if you just go and needed brain surgery, they usually don't use more than a very local anesthetic, if at all, because there are no pain receptors in the brain itself. It's just kind of ironic when you think about it. Okay, endorphins. You guys are all going to take a pharmacology class with Dr. Gerber, and I want you to impress her, okay, because you have a great understanding of opioid receptors. So, opioid receptors are called mu, kappa, and delta, okay? So if you can think about a fraternity or sorority, all right, mu, kappa, delta, you know, in college, what do they usually do? And this is just a complete generalization and really not true necessarily at all, but let's just go with it. What do? They drink a lot, they probably do some drugs, and they're always trying to feel good, okay? Those are your opioid receptors. That's how I want you to remember or picture them, okay? So they're sitting there, and if you open your hands and do kind of like a Pac-Man sign with your fingers and your hands, and you create these like open receptors that are there, and they're just sitting there to receive opioids, okay? So if you have endorphins released in your body from something wonderful, so now would be a good time to eat your chocolate, eat something spicy, maybe rub, you know, your really soft cat's fur, something that's going to release endorphins inside of you. They're going to actually go fit in those opioid receptors the same way that the drug class of opioids works. Okay, they also fit in those opioid receptors and they block pain transmission. So when you give an opioid to a patient, that is why it works. Okay, you're actually filling that opioid receptor and blocking the pain. So please remember mu, kappa, and delta as your opioid receptors. Okay, those are those guys sitting there open, waiting to go. I will also note that they found that in addition to the other things we mentioned, meditation and controlled breathing exercises also release endorphins, and that is actually a research-based conclusion in the body. So this is a picture to give you more of a visual on what we're talking about with those little, see the little opiate receptors here, okay? And you see an opiate filling in those spots, okay? And here are the pain receptors, so these are the nerve endings, wherever they may be in the body, dishing off to wherever they may be in the body. And here's a cross section of the spinal cord again, okay? Now, actually, before we go forward, why do you think sexual activity would work in blocking pain? How do you think that would help in our survival? So it's just something to consider. If you were out in the wilderness living, okay, with predators, say lions, okay, and let's say you got your leg bitten by a lion, but you were able to get home, you're in a lot of pain. By engaging in sexual activity, that pain would be blocked and you would be able to reproduce despite the fact that you were injured. So part of the thought is there's a reason that endorphins are released during certain activities. Exercise. Think about exercise so that you can run away from that lion. You don't feel that pain from that bite you have. You don't feel the pain. You're able to sprint once you get home and you're safe to wherever you live. That's when you feel the pain from the bite. Same thing happens in football. Football players are they're hit, but they're actually, they have enough endorphins released where they're able to run and get to where they need to go. They don't feel the pain until much later, right? So let's talk about and think about why these different things block pain, okay? So let's use morphine. So by the way, where does morphine originate from? Well, it's on the slide, so that's a hint. Poppies, okay? So despite what you may know about a lot of medications, most of them really came from something natural that we now synthesize in a lab, but it's still the same basic components. But a lot of them came from natural sources, and I think that's important when you have a patient who's against using medication, which I was at one point, that you do educate them that a lot of these things came from natural sources and are naturally, based in that way. Okay, so how do poppies work? How do they block pain? How does morphine work? Well, you just learned about opioid receptors, so you know that morphine as an opioid binds to the opioid receptor sites, and that's how it blocks pain. What about acupuncture? What are some of the thoughts that you have on why acupuncture works? So little needles going into different parts of the body. So there are theories about it, and the two basic theories are that it actually releases endorphins. The second one is that it's a large nerve stimulation, which blocks out the smaller diameter nerve stimulation, just like the gate control theory, okay? TENS, if you've heard of TENS or maybe you've experienced it as an athlete, is transcutaneous electrical nerve stimulation. If you're stimulating a nerve, you also could be doing the gate theory again, and it would be closing the gate by stimulating with vibration and touch. Okay. Stress. How does stress work? As we talked about a few minutes ago, a football player running. Stress actually releases endorphins, can release endorphins. The endogenous opiate system is what we refer to that, which again fits in those opioid receptors and blocks pain. I'd like to share with you some of my favorite street names of opioids. Captain Cody, Schoolboy, Doors and Fours, White Stuff, Pancakes and Syrup, China Girl, Tango and Cash. So these are some of the on-the-street current names that kids are calling Robitussin AC, that's the Schoolboy, Tylenol with codeine, Demerol, and some of the other opioids, just in case you overhear interesting conversation with somebody. Okay, so when we're describing pain, there are some things that we have to know and discuss together. So your pain threshold. So we all read this definition, point at which a stimulus is perceived as pain. Okay, that's great. What does that mean? Okay, if someone has a different pain threshold. Let's say I'm giving a massage to somebody on their back. One patient is a triathlete, and the other patient has fibromyalgia. Fibromyalgia, if you're not aware, is a condition in which somebody is having chronic body pain, muscular body pain, okay? Now, if I use the same pressure and the same technique on the triathlete and the fibromyalgia patient, is their pain threshold going to be the same? No, the fibromyalgia patient may have a much lower pain threshold. And I'm actually speaking from experience with this. My fibromyalgia patients can barely take a light brushing on their skin. Okay, that's about the most pressure they can take. What about perceptual dominance? Okay, so pain at one location may cause an increase in the threshold in another location. If we were in class, I would talk about a movie called Major Pain. And it's a ridiculous movie, but if you've seen it, you know what I'm talking about. It's a comedy, but he's in the war zone, and he happens to have someone who's in a lot of pain from a wound. And he actually asks the guy if he wants him to do something to take his mind off that pain. And he holds his finger and breaks, I think it's his pinky finger. And by doing that, he took his mind off the pain that he originally had by giving him this new pain by breaking his finger. I know, it's not the best example, but it gets the point across. Okay, so if you have pain in one area, it may actually cause an increase in the threshold in another area. Okay. Finally, pain tolerance. The duration of time or the intensity of pain that a person will endure before initiation of pain responses. So, what is a pain response? Okay, pain response, if you want to know right now, when you want to go experience it, go pull out a couple of your nose hairs. I'm not kidding. Just go pull some out and see how you feel. Or go get some part of your body waxed and then come finish the video, because that is going to give you an idea of what a pain response is. So you could be sweating, okay? You can have your heart rate can pick up, okay? And so take a look at that. There are pain responses. There's something that we see people change. Certainly, what happens to your blood pressure when you're in pain? Hopefully you said that your blood pressure went up, okay? So you could have a patient who has a blood pressure of 160 over 95, okay, which is high, and you're looking at it, and they're in acute pain. They haven't been given any pain medication. Well, you may find that by treating their pain, they may come back down to a normal blood pressure level, okay, because there are certain responses of the body to pain. So go pull out some nose hairs and come back. Acute pain. Are there people in the world that exist who do not feel pain at all? The answer is yes. Is that an advantage or disadvantage to them in terms of survival? It's actually a very bad thing. They have nothing to tell them that they're doing harm to their body. Okay. Now, acute pain, you can think about a lot of examples of acute pain. But the main thing is, if something's hurting you, you're going to get away from it. Okay? You're going to survive. That's what we are meant to do. So how do we measure pain in our patients? And we already talked about the numeric scale. Here's the Wong-Baker FACES scale. So we use this a lot with kids. But sometimes we use it with adults if they're not able to hear us or perhaps quite understand. They can figure a lot out by these faces. Here's some of the manifestations of pain. Okay, so we're looking specifically at fear and anxiety. All right. So when you look at this list, which one of these actually, are any of these surprising to you in response? Some of you may say actually dilated pupils may actually surprise you. Some of you may think tachycardia. I had a guess. Why would dilated pupils be something that would happen when you had pain? Or perhaps when you have fear or anxiety, sympathetic response. Why would our pupils dilate? What does dilated pupils allow to happen? It allows more light to get through. And so if you're in a dark place and you're afraid that something is stalking you, you're going to get more light and be able to see better. So diaphoresis, we talked about that. Now, elevated blood sugar levels. Perhaps that's not something you would think about. Why would elevated blood sugar levels help us survive when we're afraid? Okay, when we're being stalked by a lion. Okay, it makes the sugar available in our blood for our cells to use very quickly for our muscles to get out of there, right? So think about how elevated blood sugar levels, if you're constantly feeling anxious all the time or afraid all the time, what could happen to your body with this kind of response, okay? Notice general decrease in blood flow as well. Okay? You have to know what somatic pain is and visceral pain. We talked about visceral earlier, being organ related. Tends to be very poorly localized, okay? Meaning you're not really able to explain it very well where it is. Whereas the somatic pain tends to be pretty localized. Like I say, oh, where does your ankle hurt? It hurts right here, okay? Where I cut it or where I scraped it. Or this is the bone I broke. It hurts right here in my kneecap. That's somatic. But when you're talking about organs, it's very less clear where your pain is. You just have pain, and it's in that area, but you can't quite point to it, okay? Because there's less nociceptors there. Next, we're going to talk about referred pain, and I hope you guys are doing okay. Feel free to please go have a bowel movement and urinate whenever necessary. and come back to me. Referred pain is very interesting if you've never heard of it before. And it's constant, it's a pattern that we've determined for most human beings, okay? So it's when you have an area where you're actually having tissue damage or cell damage, but the pain itself is in a different area, okay? Classic example. Think about what you've learned about a heart attack and what are the classic symptoms of a heart attack. You'll remember probably, oh, the left arm, right? Or the left shoulder. They're going to feel it in their left, maybe chest and their arm or their back, okay? That's classic referred pain from the heart. So the heart, you guys know where the heart is. It is on the left side. But is your heart in your arm? No. Is it in your back? No. But you're still going to feel pain there classically as a male. We will talk more about this in the future, but just to say it, women are at extreme risk. They're more likely to die from a heart attack because their referred pain tends to be in their abdomen, and different parts of their back. Okay? This slide doesn't actually necessarily correlate with that, but anyway, it gives you an idea of other referred pain. But in terms of a heart attack, women tend to feel their referred pain in their stomach and in their back. And that's very non-specific, that they miss heart problems, heart attacks, okay? And too much tissue dies. Okay, here's classic male, okay? So the heart muscles are not giving enough oxygen. That's angina. And they can have chest pain that radiates to the jaw, shoulder, arm. Okay. Please watch this TED Talks. It's pretty short. I'm not going to have you watch it here right now. But take a click on that link when you're done, or maybe tonight. And it's very interesting. It talks about chronic pain. What I want to mention about chronic pain is that because it's chronic, from the definition of chronic, it's still occurring. It's happening over time. It's very, very resistant to medical treatments. Very resistant. That means we've tried. We've done lots of things to try to help different types. I mean, think about a chronic low back pain. How many people do you know who have chronic low back pain? Okay. So this is defined as lasting at least 3 to 6 months. And you can see, it could occur suddenly. It could occur slowly, which is insidiously. All right. It could be all kinds of different areas. But what you will see with chronic pain is that it produces significant behavior changes. Okay. So someone may stop being so energetic. They may stop being so bouncy. They may look more down, more quiet. They may actually start to remove themselves from public situations. Perhaps you may even see a personality change. That's something I've certainly seen with chronic pain. What else can you see? Depression, okay, anxiety. Sadness, isolation, fatigue. Fatigue is a really big one. Being in pain takes a lot of your energy. It really does. Healing takes a lot of energy, but being in pain absolutely takes a lot of your energy. And these people are very tired, generally. Okay. Here's a couple examples of different things that can cause pain, chronic pain. Okay. And they all have their own ways of being treated. Neuropathic pain, take a look at this beautiful photo. So I would ask you, where did this injury come from? Okay. And what we see, if you remember when I was talking about diabetic patients who have neuropathy, tends to be the lower extremities, peripheral, okay? And with diabetic patients, if they can't feel very well in their foot, which most of them cannot with neuropathy, they lose that feeling, that ability to know that something's harming them. They actually can get very bad infections in their lower extremities and not quite realize how bad it is because they can't feel it appropriately. There's not the correct response there. And it can also become an issue with the arteries and the veins, and you can get ulcers as well. Okay? So remember what neuropathy is. Okay, it's a disease of the nerves. You can also have central neuropathy, which is going to be an example of like the phantom limb pain that we were talking about. I would like you to also realize that 30% of neuropathies are diabetic neuropathies. Okay, that's a pretty big number when you take a look at something like that. 30% are from diabetic neuropathies. Acupuncture, acupressure, and massage have all been found to be very, very helpful, not only with just chronic pain in general, but neuropathic pain. And we do have certain medications that help as well. And finally, in conclusion, I wanted to just briefly talk about the changes that we see with ages. So it used to be, believe it or not, that it was thought that infants did not feel pain. And they actually used to do open heart surgery on infants with no anesthetic whatsoever. Okay? That was wrong. That was a misconception. And we don't do that anymore. We're very, very cautious of our young patients, especially babies, and realize their pain pathways are functional. Okay. Now let's talk about the opposite spectrum. So in aged patients, okay, those towards the other geriatric population, they actually have an increase in the pain threshold. So what does that mean to you? If you're thinking about a patient and they have an increased pain threshold, you're like, oh, cool, good for them. But is this really a good thing, or could this actually put them at more risk? They have less of a warning system. Okay, their alarm system is dampened, so to speak. So this could actually be not a good thing. And we have to be more careful when we see them, because they may not feel pain from some smaller injuries until it's a little too late. They're more likely to have peripheral neuropathies, okay, and skin thickness changes. Okay, and that actually brings our lecture to a conclusion. I hope you guys had a good time and it wasn't too strange. But do let me know if you have burning questions. Enjoy this topic, because this is going to be how you spend a lot of your time, is controlling pain on your patients. And make sure that you do different things to keep your endorphin levels high, okay, while you're going through massage school. All right, and I will talk to you soon.